welcome. This is the first session of respiratory physiology and probably the most relevant thing out of the whole first part course. So the structure of my tutor pretty much I'm just going to ask lots of questions. I really want this to be exam focused, so lots of SAQ practice. I'll do some things as SAQs, as 3-minute SAQs, as 5-minute SAQs. So have a pen and paper with you so you can just get into the habit of writing things down. I found that for this exam, for so long I was just studying from the textbooks and constructing these short answer questions with a lot of time to spare. I just realized that just wasn't the way I needed to do things. So, ever since starting really, ever since starting very exam focused practice, everything really changed. I found that my retention was far better. There's one of those concepts that if you, instead of just studying things or studying facts, study questions. So, or whatever you're studying, ask yourself a question and write it down or speak it out, and that's a really better way of getting retention. Good. We'll do lots of viva practice. I'll put people on the spot as well, but just know that we don't care if you get it to say a terrible answer or a fantastic answer. This is about learning and getting as good as you can from mistakes now, so that on the day of the exam you're doing as best as you can. We'll go through lots of classifying. Seems to be a real big thing with this exam, classifying your answers, definitions, and drawing diagrams and describing diagrams as well. Let's get cracking. So I'll try to, essentially try to go through the whole respiratory syllabus in these 3 sessions, and hopefully there'll be nothing else that'll be asked on this exam. Like that's pretty much it. And we'll try to layer the knowledge. So I'm just trying to give you the bare essentials to pass, the detail you'll need to answer the harder questions, hopefully guarantee a pass mark in understanding, but I'll also go through a lot of the questions that I was asked, and some things that I've predicted that can be asked, and try to tease out more of the understanding points as well. So hopefully taste of SAQs and viva style questioning, and this is what we'll go through in this session here. And I've sent out an email with all the objectives that we'll cover over the next session and the next session as well. So if you want to read ahead, that's all good. I'll give you guys a set of notes. I won't give you the slides, but I'll give you a set of notes relating to all of these after, so today or tomorrow. So that's all the outcomes. Okay, so I think the first thing we'll do, now, this is actually one of the syllabus points, and I thought this is a really good example of where you may have never formally, learned describing the structure of the chest wall and diaphragm, like formally actually learned that. But I want you to have a go at this. Just look at the structure and just write anything, just write actual facts about it that you know. So take a couple of minutes to do that. Let's actually go through structure and function of the chest wall first. So structure and function of the chest wall, not the diaphragm. So give you guys a couple of minutes, just write down your answers, and I'll ask someone at the end of that. So I might ask Mason just to share his answer at the end of that, if that's all right. Take 2 minutes and I'll let you know when.
Shut myself off mute. All right, so I generally broke in my structure into the thoracic cage and then the diaphragm as the components of the chest wall. So with the thoracic cage, then you've got your sternum, your left and right 12 ribs, and then your intercostal muscles, your external and your internal, as well as your parietal pleura on the inner surface of your thoracic cage. Compared to the diaphragm, which is a large, somewhat bell-shaped flat muscle.
Actually, I'll go to diaphragm in a second. Tell me about the function of the chest wall.
Sure. So the chest wall provides a protective function for the internal organs. It also provides by supporting the parietal pleura, it provides a pressurized space to facilitate a negative intrapleural pressure, which is important for your respiratory mechanics. It's probably the first 2 that really jumped to mind. Yeah.
First of all, that was a good answer, Mason. Now the thing is, have you studied that?
Yes, about 6.5 months ago.
Okay, good. But 6.5 months ago. Now, the fact is that in this exam, you will have, everything you'll be asked, actually the majority of stuff you'll be asked will be 6.5 months ago, 3 months ago. Like it's just painful to think that you got to learn so much. And the last time you studied something was so long ago. So look, first of all, I like that you just had a format. You need to just get facts on the page. And a lot of the time you may get a question that is a bit of an icebreaker question, but the icebreaker question can be really out of the blue, or, something that you haven't thought about before. And your ability to just go, it's just a question to be answered. I'm just going to say, look, the structure, and just imagine it. And you just describe what the structure is. You just gave me facts that are true, and you gave me reasonable functions as well. So yeah, really good. And that's kind of, I feel like a big part of this exam is just trying to drag facts from your memory and just putting it on paper. So functions, it protects the contents of the cavity, provides attachments with one extra thing. You could mention for muscles of the neck, thorax, upper limb, abdomen, and back. And then, the muscles of the chest wall elevate and depress during respiration. I like the fact that you kind of, you didn't say exactly that, but you described that it provides this cavity that, you can get this negative pressure state when the muscles contract. So that's really good. Let's go for the diaphragm. The diaphragm's got a few more points. So again, if you imagine all the ways you could describe a muscle, which is, what it is, where it is, the nervous supply, what kind of holes it's got in it in this particular case. I want you guys to take 2 minutes to describe structure and function of the diaphragm. Go for it. And at the end of that, again, I'll just keep picking on people. So don't feel too bad if I pick on you. Dee, if you're happy to give me an answer at the end of 2 minutes, that'd be great.
Unmute myself. Okay, so the structure, describe what it is. I wrote it's a flat sheet-like muscle with a dome-shaped appearance, and quite a thin muscle made out of mainly slow twitch muscles, or not easily fatigable muscles. Where is it? It sits basically between, it divides the thoracic and abdominal cavities, and sort of sits, and then I went on to its structure to describe like its attachments. So it's made up of a central tendon as well as arcuate ligament, which attaches to sort of the lower ribs. Can't remember which numbers. And then it's also got like a right and left cruce, which makes up the diaphragm. And then the level depends on, you have 3 points there, La. I'm not really sure exactly what you meant, but I was thinking like if it was during breathing, whether it was a quiet breathing versus forced expiration.
Yeah, absolutely. The breathing is definitely the obvious one. So that's fantastic. And yeah, I just put that as a memory point for me. Is there any other things that would affect its position that you can think of?
Yeah. So also like a difference. I put pregnant. I don't know if pregnancy does it, but anything which sort of distend your abdominal.
Absolutely. You'll learn that in this exam, everything is about pressure and gradients and that kind of thing. So yeah, you put a baby in your belly, or you put obesity there, or any kind of tumor or anything else. It will go upwards. Absolutely. Anything else?
I put positioning, but I don't actually know what I meant by that, because I don't think it's actually supposed to change if like just a normal person lies down.
I think it does.
Yeah.
So if you lie down, your diaphragm will be less depressed.
Yeah. Oh, actually, yeah, that's right. And
yeah.
Okay, cool.
Anyway, that was good. Your gut feeling was right. You're smashing this. Keep going.
Nervous supply. I just put C3 to 5.
Yeah, that's right. That keeps the diaphragm alive. Now, so it sounds like you're not sure about.
But then.
Sounds like you're not sure about
Sorry?
the sensory. Sounds like you're not sure about the sensory function. Is that right?
Yeah.
Good.
Yeah.
If you were to,
I was about to say, yeah, I don't really.
You were to make it up, like what would you say the innovation sensory is? If you were to just have a guess.
It could also go through to C3 to 5, but also no, intercostals.
Yeah, and which intercostals do you reckon? Just give me a range.
Somewhere between like T7 to T12. No, it's too low. Fuck. Sorry. T5 to T10.
And it doesn't matter, right? This is good. So keep going. We're going to get to that, but you're actually more correct than you think you are. So
okay.
First of all, you're correct about motor.
It's all coming back to me.
That's right. C3, 4, 5 keeps the diaphragm alive. Everyone remembers that, so that's fantastic. Whoever made that up. And then sensory, it is partly C3, 4, C3, 4, and 5, but also it's the low intercostal nerves, anything that's around that area. For example, and a lot of the body is like this. The diaphragm is just the weird one where you've got C3, 4, 5 innervating down there. But, say a blood vessel goes over a joint, it supplies that joint. If nerves go past a structure, it supplies that structure. The body kind of just makes sense most of the time. And how about the apertures? You mentioned the crew and the things like that. So
yeah, so there's 3 apertures. I've got cable, esophageal, so the cable hiatus, the esophageal hiatus, and then the aortic hiatus, so the cable has the inferior vena cava going through it. Esophagus has the esophagus going through it as well. I think vagus nerve. And then your aorta the aortic aperture has the aorta going through it. And then does the nerve go through there? No. Zygous vein, and I don't know.
No, that's good.
One more thing, but I can't remember what it is.
That's fine. And now let's go to function. Actually, I'll pick on someone else because I've already grilled you enough. Who wants to tell me about the function of the diaphragm? Might just go to the next person. Luke Fletcher, are you happy to just volunteer some information? Yeah, go for it.
Yes, thank you, Ila. So I guess the first thing is that upon contraction, the diaphragm moves inferiorly and therefore expands the intrathoracic space and results in pulmonary expansion through introduction of negative pressure into the chest, into the intrathoracic cavity, and therefore facilitates ventilation. So another function, I guess, is probably in respiratory reflexes like coughing, sneezing, and those sorts of reflexes as well. And those serve protective functions for the respiratory system. It also probably provides an element of protection or isolation of the chest cavity, the thoracic cavity and the abdominal cavity. Its function also pinches off the esophagus and reduces esophageal reflux and forms the lower esophageal sphincter.
Fantastic.
So that's probably all I've got.
And what does it do with the caval opening and the aortic opening?
I'm not sure what happens dynamically, but it's a hole in it that allows blood to go up and down between the thoracic and abdominal cavities. And
that's right. And look, so you're already doing well. So I'm going to ask you this then. What would it possibly do on inspiration if you wanted to facilitate blood going up? I know that this sounds weird, right? If your muscle contracts, it should be doing something, but it actually feels like it does the opposite when it comes to the caval opening. What do you reckon it does? Does it close it off or does it open it? Well,
upon contraction, negative intrathoracic pressure is going to increase venous return.
Yes.
It would be counterproductive for it to block off the IVC. So I would say that upon contraction, if something does happen dynamically, then the caval hiatus will open to permit venous return to come back to the chest. So.
Yeah, exactly. That's exactly right.
Yeah.
And it's just, when you look at the diagrams, it's just really interesting the way the muscles are orientated so that when they contract, they open something rather than close it. So it's a very, it's the opposite of sphincter type muscles, which I guess are circular, so they can contract. These are arranged in the format that they open as they contract.
Mm-hmm.
So yeah, so you described all of that very well. And so both of you guys described all that really well. Just to rehash, you described what it is, you described where it is, and it's such a captain obvious of statements. It's it's between the thorax and the abdomen, just below the ribs, above the liver, whatever it is. Just give it a location. Level depends on exactly what you said. So level of respiration, intra-abdominal contents, as well as the position of the patient. Nervous supply is what we mentioned. I'll get you some information about that, and then the main muscle involved in respiration, venous return. Because you get the increased abdominal pressure and decreased intrathoracic pressure, so it aids venous return, and it's also anti-reflux as well. I'll get you the, yes, the motor is the phrenic nerve C345, and then sensory centrally is 345, but peripherally it's the intercostal nerves of T5 to 11 and subcostal as well. So that's fantastic. So you're pretty close to that, if not exactly right. Yeah, good. I always used to think that's such a weird part of the syllabus that you'll never be asked, but I thought that it's a really good example of just making up an answer that you think is reasonable. So knowing that, let's move on. Outline the anatomy of the lower airways. So what is the main function of the airway? So I might just ask some people about this. I'll just go through this now. Okay, so write down, just wondering how best to do this. Okay, everyone write down the answer to these questions, and then I'll ask Zach at the end of it. I'll go through a few people, so I might ask Zach and Meg a few questions about this. So the airways, I want you to answer out loud to yourselves. What is the main function of the airways? Take a few seconds to do that. Actually, write out all these questions. So what are the main function of the airways? What are the interesting properties of the blood-gas interface? What about the airways? So tell me about the conducting zone, the respiratory zone. What's the anatomical unit of the lung and define it? And what is the method of gas flow? And where does dust settle?
So I've got that it's to transmit gas to and from the alveoli for gas exchange to occur.
Mm-hmm.
And I've also said that it filters the inspired air and it warms and humidifies it to improve gas exchange.
Sounds good. Tell me about the blood-gas interface.
Yeah, I was trying to think of more interesting properties. Predominantly what I've got is that it's very thin and it has an extremely large surface area for its total volume.
Fantastic. Do you have any numbers for that?
I feel, I could be way off. I'm bad at estimating these things. I feel like the surface area, this is going to sound insane. Is it 50 to 100 square meters?
It is. It is. That's exactly right. I think that's exactly right.
And then the distance would only be like a few micrometers.
Yeah, good. It's 0.3 micrometers thin. So really good facts to know. It's about 300 million alveoli. I think you obviously have to learn quite a few numbers, and I feel like those are probably numbers that are worthwhile. They'll come up again and again. So 0.3 micrometer thin membrane or barrier and 100 square meter surface area. What law does this relate to, Zach? When you're talking about gas exchange or
Fick's law of diffusion.
Fantastic. What is that law?
So it's the equation, or like the rate of diffusion, is equal to the diffusion coefficient, which in itself is inversely proportional to the molecular weight and solubility constant. And that's multiplied by the area for diffusion, the pressure gradient across that, the thickness of the membrane, and then that's all divided by thickness of the membrane.
Good. So essentially there's a few formulas that you guys will have to quote time and time again: Hagen-Poiseuille equation and Fick's law. And you can. It seems like with this exam you can almost invoke those two in any situation, but this one's very relevant to this. So Fick's law of diffusion. The rate of transfer of this substance is proportional to the pressure gradient or concentration gradient. So P1 take away P2 times area over thickness. Area helps it, thickness doesn't help it. So area over thickness times by solubility over the square root of the molecular weight. Mm-hmm. Good. How about the conducting airways? So pretty much I've just said here, it consists of a series of branching tubes become narrow and shorter as they penetrate deeper into the lung. Conducting airways are, the trachea. So where does the respiratory zone begin? Zach?
When we change from terminal bronchioles to respiratory bronchioles, which are those which then have alveoli branching from them. Fantastic.
And up to that point, what do you call that? The conducting zone, like what is another name for that?
Anatomical dead space.
Fantastic. How many mils is that?
150.
Fantastic. Good. Now, this is a bit of an interesting question. So what's the anatomical unit of the lung?
I don't know if I'm going to... asinus? I don't know how to pronounce it. but
Yeah,
ACINUS.
As long as you don't say another word that sounds like it, that's fine. Okay, the portion of the lung distal to the terminal bronchial is called the acinus. It's the anatomical unit of the lung. So any part distal to the terminal bronchial. As you're learning all your organs, you'll probably be asked this. So learn the anatomical unit for the liver and the kidney, because it's just one of those, again, throwaway questions that is thought to be a base knowledge question, even though we rarely think about it in our clinical practice. So anatomical unit is that portion below distal to the terminal bronchial, and it's the acinus. What's the method of gas flow, Zach, in the lungs?
I couldn't remember the exact term, but in the conducting zone, it's like mass gas transfer or like something of that nature.
Yeah,
it's like the entire transfer being moved because of your pressure gradient.
Yeah, they call it bulk flow. That's right.
Yeah, bulk flow. Thank you. Yeah, and then when you get to respiratory terminals, respiratory, then it's just passive diffusion for the last.
Yeah, good. And why is that?
I assume that it's because the radius is now so small that the pressure gradient isn't, I guess, transmitting across that final branch or something.
Yeah, so the way I like to think of it is your trachea is about kind of that big, it's maybe a few square centimeters. But once you get all of your terminal bronchioles together, that cross-sectional area is so huge that the velocity drops, the bulk flow, the pressure gradient, the effect of the pressure gradient is so minimal because your area is so vast that now pressure gradient is far less of an issue, far less of a factor for gas transfer rather than diffusion. So knowing that, where does dust settle?
At that junction between the conducting zone and the respiratory zone.
Yeah, good. Yeah, the terminal bronchioles. And I just think that's just a beautiful thing, that the things that would cause a problem, cause any kind of obstruction to airflow, then get sorted out before they reach the respiratory zone. So it's one of those beautiful, like the human body is designed terribly in so many ways, but there's some things like that you just think that is beautiful.
Hold on, yeah.
Right. Good. Now this is something, again, I don't think we were asked too much about, outlining the anatomy of the pulmonary and bronchial circulation. So just to go through it, pulmonary vessels form a series of branching tubes, a pulmonary artery, capillaries, and pulmonary vein. Interstitial arteries and veins and bronchi run together. Then at the periphery, the veins move away and pass between lobules, arteries, and bronchi, traveling together down the center. And again, whenever I thought of this, I just try to think of a diagram and just describe it in, just with some reasonable words, just to get something out. Someone told me very early on in the piece that you will fail this exam because you're learning minutiae about stuff. And then he goes on, you deserve to fail. And that really was confronting to me, because I thought, oh wow, I've been trying to learn everything about everything. So there's some things that you just don't need to know too much about. And this is probably one of those, but you need to have this just a little bit of knowledge about such a broad area of things. And those of you who've probably been studying for 6 months or so have probably realized that you just can't know everything about everything. Not in the way you used to be able to back in university days, or especially high school days, where you could literally learn everything on the exam and pass okay. Is that something that's pretty common? Raise your hands. Have people told you that? Just don't focus on minutiae? Okay, good. And then the ironic thing is then they will start asking you minutiae. But just remember that's only because you're doing well, or they're not an exam. Like say in the exam, you start getting asked really crazy stuff, that means you've passed and you're going for the prize. So just be really positive about that. But otherwise, yeah, if it's someone who's not an examiner who's asking you minutiae from the start, then hey, they're not an examiner, just play the game. Okay. Does anyone have an answer? What's the diameter and what's the resistance, and how much time does the red blood cells spend in the capillary? Anyone can volunteer if they have even an inkling of the answer.
Is resistance like 1 wood unit compared to systemic? It's like 20 wood units.
Yeah. I
can't remember what that is, what the actual alternative units are for a wood unit.
I don't have the exact number on me, sorry, but
like 160 dynes versus 1600 dynes. Oh yeah, 1 versus 20 wood units.
Yeah, good.
Yeah, that's why I chose not to remember the dance. Yeah.
Yeah.
So it's and is it high or low, the resistance?
Very low.
Fantastic. What is the diameter roughly?
0.7 micrometers.
And 0.7 micrometers, as in the diameter of the capillary?
Yeah, it permits one red cell at a time, doesn't it?
Yeah, I've got here 10 micrometers, which is roughly the size of a red blood cell.
Okay, cool.
That's right. We can fact check that. How much time does it spend in the capillary?
Usually about 0.75 of a second. That's sort of the...
Exactly. And that becomes a bit of an issue when you talk about diffusion and perfusion limitations. Good. So what does the bronchial circulation do? Tell me about that. Actually, someone can volunteer this. What does the bronchial circulation do? And how much flow is it compared to the pulmonary circulation? This might be something that people have studied recently or not.
Yeah, so my understanding is that it essentially comes off the aorta and then delivers oxygenated blood to the pulmonary parenchyma and bronchi up to the level of the terminal bronchioles.
Okay. And what's the flow? Is it a lot of flow? Is it 5 liters per minute? How much is it?
I'm not sure. I guess if I was to quantitate how much versus the pulmonary artery, maybe like a 80-20 split.
Yeah. In West, they just talk about it being a fraction of the pulmonary circulation. And can you function without it?
Yep.
Yeah, why is that? How do you know that?
Lung transplants.
Exactly. Lung transplants, they do not reattach the bronchial circulation, and you can function without it.